शेयर कर देना, हम देखते रहेंगे कोई प्रॉब्लम।
Hi guys, welcome to this marathon session of surgery. This is Dr. Pritesh Singh, your surgery faculty. Hi guys, welcome to this marathon session of surgery. So Unacademy is celebrating Republic Day. You can save up to 20% on all medical PG subscriptions, and this offer is valid till 31st January only. So you can subscribe. What you will get along with this? You can get free notes version 1.0 worth rupees 7,500 with 1 year and above combo, and you can use the code Dr. Pritesh, DRPRITESH. We have NEET PG Vitals also. In this NEET PG Vitals, there are recorded videos for comprehensive NEET PG preparation, in which 800 plus hours of recorded classes are there by top educators of all 19 subjects. There are clinical previous year questions, MCQs, there are practice questions at the end of each session. So here you can subscribe this NEET PG Vitals also for the special launch price of 11,999. And there is Iconic subscription, Unacademy Iconic subscription, where you can get benefits of Prep Ladder plus Unacademy Live plus Prep Ladder physical notes. And this offer is also valid till 31st January. So now let's start the session. Some of the students are asking that, sir, you will be taking classes TNT. I will be taking the whole surgery in Unacademy. I'll be taking all classes, whole surgery in Unacademy. Okay. Now see this question. Which of the following statement is incorrect about thyroidectomy? I'm waiting for your reply. First tell me, what's your answer? I'm waiting for your reply. What is the correct answer? Tell me. Mohammad Sajad, Petri, Arshad, Elsa, Shefali, Bharat. Which of the following is incorrect related to thyroidectomy? Okay. So here, first option is that superior thyroid artery, it is ligated close to thyroid. Second option, inferior thyroid artery, it's ligated close to thyroid. Most commonly injured nerve is recurrent laryngeal nerve, and middle thyroid vein is ligated first, followed by superior and inferior thyroid vessels. I'm waiting for your reply. Shreya, Vivek, Bharat, Rameshwar Naik, Sonali Ranjan. Majority of you want to mark C, some of you want to mark D. Mrunal Gunjal is also there. She wants to mark D. Shreya Kumari, C. Oikawa is also there. Okay, now see, what happens in thyroidectomy? Whenever we are performing thyroidectomy, this question is related to anatomy as well as surgery. So in this case, first you see the anatomy. Here, this vein is middle thyroid vein. So whenever we are ligating the vessels, middle thyroid vein is a very short vein. And if you are not going to ligate this middle thyroid vein first, what happens? This vein will be avulsed. And if middle thyroid vein will be avulsed, there is increased risk of air embolism. So during ligation of vessels, the first structure ligated is middle thyroid vein. After that, the second structure ligated, that is superior thyroid vessels. So here you can see this is thyroid artery, and here you can notice that this is the vein. So this is artery and this is the vein. After that, we are going to ligate what? Inferior thyroid vessels. So this is vein and this is artery. So first structure ligated, middle thyroid vein, followed by superior thyroid vessels, followed by inferior thyroid vessels. Okay. Second, we have to ligate superior thyroid vessels close to thyroid. Why? If you are going to ligate the superior thyroid artery away from thyroid, you are going to injure external branch of superior laryngeal nerve. You can see here, this is superior laryngeal nerve and this is internal branch, this is the external branch. So to prevent injury of external branch of superior laryngeal nerve, the superior thyroid vessels should be ligated close to thyroid. Third important point, you can see here, this is inferior thyroid artery. Inferior thyroid artery is having a branch known as parathyroid artery. And this parathyroid artery, it's an end artery. This parathyroid artery, it is going to supply what? Parathyroid gland. So if you ligate inferior thyroid artery away from thyroid, what will happen? There is vascular infarction of parathyroid gland. So to prevent vascular infarction of parathyroid gland, even inferior thyroid artery is also ligated close to thyroid. And one of the question where you people do the mistake, recurrent laryngeal nerve is not the most commonly injured nerve during thyroidectomy. It is what? It is external branch of superior laryngeal nerve. Most commonly injured nerve during thyroidectomy, it is external branch of superior laryngeal nerve. It's not the recurrent laryngeal nerve. So see the question. Which of the following is incorrect related to thyroidectomy? So you see, superior thyroid artery is ligated close to thyroid, correct? Inferior thyroid artery ligated close to thyroid, correct? Middle thyroid vein ligated first, followed by superior and inferior thyroid vessels, correct? Most commonly injured nerve, it's not the recurrent laryngeal nerve, it is the external branch of superior laryngeal nerve. This is external branch of superior laryngeal nerve. So what is the correct answer? The correct answer for this question is C, option C. So majority of you have marked the correct answer. So you have to remember that recurrent laryngeal nerve is not the most commonly injured nerve. It is the external branch of superior laryngeal nerve. Next question. A 3 days old baby was brought to the hospital with history of passage of greenish yellow fecal discharge from umbilicus. What happens? There is greenish yellow fecal discharge from umbilicus. Clear? What shall be the embryological cause of this condition? I am waiting for your reply. First you reply, then I will discuss the question. Yes, Raja Siddiqui, Dr. Dreamer. Dr. Raja Siddiqui wants to mark C. Dr. Dreamer wants to mark B. Hashi Rama is there. Anubha Singh, Lovely Dubey is there. Majority of you are Priyanka, Kaushik, Bharat, Maria, Elsa. Majority of you are marking option number B. Wrinkle Totlani, Rameshwar Nayak. Rameshwar Nayak wants to mark D. Trilok Chand D. Muhammad Shahjaz, Swati Dulla D. Okay. Right. See, first, what is the embryological basis? So it's very easy to understand. Have a look. Here what you can see, this is vitellointestinal duct. This is what? Umbilicus, and this is ileum or small intestine. Both of these are connected by vitellointestinal duct. Whenever there is patent vitellointestinal duct, there is communication between two epithelium lined surfaces. If it is patent, what will happen? This is known as fistula. And in this case, what will happen? The greenish discharge will be going out via the umbilicus because it's patent. Second situation, you can see this is umbilical end, this is intestinal end. So there is persistent vitellointestinal duct towards intestinal end. This is Meckel's diverticulum. It is caused by not patent, persistent vitellointestinal duct towards intestinal end. Whenever there is persistent vitellointestinal duct towards umbilical end, it's a blind cavity. So it's a sinus. Sinus is blind. Sometimes both intestinal and umbilical ends are obliterated. But what happens? In center there is some part which is patent. That is known as cyst. Which cyst? Vitellointestinal duct related cyst known as vitelline cyst. And sometimes this vitellointestinal duct, it is replaced by a fibrous cord that is known as a band. Which band? Vitelline band. Clear? How it looks like? See, this is Meckel's diverticulum. What is Meckel's diverticulum? This is persistent vitellointestinal duct. Sometimes Meckel's diverticulum, here you can see, it is attached to umbilicus with a fibrous band. Sometimes there is only a fibrous band we discussed, that is vitelline band. Here you can see it is patent, and if it is patent, this is known as fistula. Here you can see only this umbilical end is patent, this is known as sinus, and here you can see there is a cyst. Clear? Concept is clear? Now see the question. If you see the question again, the patient is having greenish yellow fecal discharge. So what? This is the bowel, this is the umbilicus, from here there is the discharge. It means what? Patient is having patent vitellointestinal duct, which is vitelline fistula. So it is not vitelline sinus, it is not Meckel's diverticulum, it is not patent umbilical end of vitellointestinal duct. So what is the correct answer? Correct answer is B. Correct answer is B, and majority of you marked correct answer B. Okay, Raja Siddiqui B, Debupam Datta B, Gauri B, Suresh Purate B. Okay, majority of you marked option number B. Clear? Now see the third question. I am reading the question, mark the correct answer, and then I will discuss this question. See the age, 19 years old female, presented with progressively increasing midline swelling for 2 months. Neck examination revealed 3 into 2 into 2 centimeter on the right side of neck. So on the right side of neck in the midline, there is a swelling extending from midline to anterior border of sternocleidomastoid. On palpation, firm and mobile. She was having enlarged lymph node in level 2 and 3, 1 into 1 centimeter. Important point, calcitonin is raised. There is increased calcitonin. All of the given below statements regarding the diagnosis of our case are true except. So which option is false in this case? There is a midline swelling in the neck with involvement of lymph node. Midline swelling. There is involvement of lymph node. First, you guys tell me what is the diagnosis, which malignancy patient is suffering from. Which malignancy patient is suffering from? Majority of you, Dr. Joy, Gauri, Yamini, Lovely, Goldie, Dreamer, majority of you are marking the correct answer. Majority of you are marking the correct answer. First, you tell me what is the diagnosis in this case. Which malignancy is there? Which thyroid malignancy? Manoj Prajapati, Swati, first people to reply, Dr. Dreamer, Dr. Raja Siddiqui, Healthy Med Talk, Sonali Ranjan, Raja Siddiqui, Mrunal Gunjal, everybody, all of you are marking correct answer. It is medullary carcinoma thyroid. Important point, you know that medullary carcinoma thyroid, it arises from parafollicular C cells and it is going to secrete calcitonin. Despite of increased calcitonin, let me tell you, despite of increased calcitonin, the calcium level is normal. In patients of medullary carcinoma thyroid, there is normal calcium, you have to remember. It is having both hematogenous and lymphatic spread. The most common site of metastasis is liver. This is TSH independent tumor. This is TSH independent tumor. Independent, and it is sporadic in 80% cases. It is familial. Familial in 20% cases. Familial means it is associated with MEN 2A, 2B. So, A is correct, B is correct, D is correct, C option is incorrect. It is not dependent on TSH, it is TSH independent tumor. So, I can see majority of you are marking correct answer. Yes, it is not dependent on TSH. So, correct answer is C. Now, this question, easy question, you can easily mark the correct answer here. You can easily mark the correct answer. Tell me what is the correct answer. I am waiting for your reply. A 50 years old female was brought to the hospital with enlargement of the breast as shown in the image. What is the preferred treatment option? Yes, Trilok Chand, Hashirama, Anubha Singh, Swati Dalla, Elsa, Devopam Datta, Dreamer, Mrunal, Anubha Singh, Kalpana. Everybody, majority of you, Dr. Joy, Harjap, Paneer Selvam, Gauri, Ashish, Sani, Suresh, Sangam, all of you are marking correct answer. What? That's a simple mastectomy. What is the diagnosis here? You know, this patient is having cystosarcoma phyllodes. Patient is having cystosarcoma phyllodes. This is also known as phyllodes tumor. So it's very, very easy to remember. Break it. It is cystosarcoma phyllodes, means this tumor will behave like carcinoma or sarcoma? Sarcoma. You know what's the difference between carcinoma and sarcoma? Carcinomas are having lymphatic spread and sarcomas are having exclusively hematogenous spread. So in this tumor, there is exclusively hematogenous spread. And if there is exclusively hematogenous spread, there is no lymphatic spread, so there is no involvement of lymph node. That's why in surgery you are not supposed to remove the lymph nodes. What is the difference between simple mastectomy and modified radical mastectomy? Modified radical mastectomy is simple mastectomy plus removal of level 1 and level 2 lymph node. Radical mastectomy is simple mastectomy plus removal of level 1, level 2, level 3 lymph node plus excision of pectoralis major and minor. So what happens? In these two, there is removal of lymph nodes also. Here sufficient is simple mastectomy. So the treatment of choice for cystosarcoma phyllodes, that is simple mastectomy, and majority of you mark the correct answer. Majority of you, Sangam, everybody, Karthik, Harjap, everybody was marking correct answer. Now see the next question. Very important question. A 50 years old male presented with right groin swelling, swelling in the right groin, located below inguinal ligament, important point, medial to inferior epigastric artery. Cuff impulse was present. So swelling, cuff impulse means patient is having hernia. In relation to inguinal ligament means inguinal hernia. You tell me which type of hernia is this? It is direct hernia or indirect hernia? Yes, Praveen Kumar, Kalpana, Dr. Dreamer, Debopam, Datta, Yamini, Priyanka Kaushik, Dr. Joy, Sangam, Sayantani Pal, Mrunal, Rameshwar Nayak, Shreya Patel, Sangam, Anubha Singh, Mahendra, Lovely, Goldie, Ashish Saini, Swati, Trilok Chand, Suresh Purate, Gauri, Paneer Selvam. Majority of you are marking the correct answer. Now first see the relation. If you see the relation, see this anatomy. This is from posterior side of abdomen. So see here. In this case you can see this is the pubic symphysis. Okay. This is the right side, this is the left side. Visualization is from behind. So when visualization is from behind, you can see here that this is epigastric vessel. This is artery. This one is inferior epigastric artery. This is. Okay. Now, if you go medial to this artery, medially there is a defect. So, medial defect, this is for direct hernia. And the defect is lateral, where exactly it is coming from? Deep ring. It is coming from deep ring. So, that is located lateral. So, this question was asked in a latest exam that which hernia is considered medial? Direct inguinal hernia, it is medial to inferior epigastric artery. So, it is medial hernia. Indirect hernia, it is located lateral to inferior epigastric artery. So, it is lateral. And you know what is the gold standard treatment for inguinal hernia? It is the Lichtenstein repair. You got it? You tell me what are the boundaries of Hazelback triangle. Via Hazelback triangle, the direct hernia comes out. So, you can see medially what you can see here? Medially, lateral border of rectus abdominis, laterally inferior epigastric vessels and inferiorly inguinal ligament. Got it? So here, since it is medial to inferior epigastric artery, this was inferior epigastric artery, it was medial, that's why it's direct hernia. And what is the gold standard treatment? Leichenstein repair. So correct answer is B. Correct answer is B. Clear? Okay, Dr. Dreamer wants to ask that, sir, please explain triangle of doom boundaries. Okay, now see, what is triangle of doom? See the diagram here. Same diagram. In this image you can see what? This is the deep ring, okay, and here you can see this is the vas deferens. This is the vas deferens and this is the gonadal vessel. So, I am making a new diagram here, you can see here. This is deep ring, this is the vas deferens and this is the gonadal vessels. And in the base there is a fold of peritoneum. So, medially there is vas deferens, laterally there is gonadal vessels, apex is by deep ring, this is deep ring, and in the base there is fold of peritoneum. Behind peritoneum like this there are two vessels which are hidden, and what are those vessels? There is iliac artery and there is iliac vein. So, iliac artery and iliac vein. So, what happens whenever a surgeon is not aware of this anatomy and he is performing sharp dissection in triangle of doom, surgeon might injure. What surgeon might injure? Surgeon might injure the iliac vessels. And if iliac vessels are injured, there is bleeding, and this bleeding can lead to death. That's why it is known as triangle of doom. Now you come laterally, here there is iliopubic tract. Iliopubic tract, there is fold of peritoneum, and in this area there are 4 nerves. In this region, if you are using electrocautery, it can lead to post-operative pain, and this is known as triangle of pain. So, this was triangle of doom and this was triangle of pain. Clear? So, the correct answer is option number B. Now, read this question. A 45-year-old housewife presented to emergency department with complaints of excessive drowsiness, decreased oral intake for past 3 days. In the last 3 years, she had difficulty in getting up from squatting position. You have seen some of your relatives also who are obese, who are lethargic. Most of the times they are sleeping in the bed, they are doing nothing. They have difficulty in getting up from the bed, getting up from the chair. She is having difficulty in combing her hair, dressing. There is increased sensitivity to cold. Skin dryness is there. Increased hair loss, easy fatigability, periorbital puffiness, dry, coarse skin, no tremors or fasciculations. First you tell me, fine tremors are features of hypothyroidism or hyperthyroidism? Fine tremors are features of hypothyroidism or hyperthyroidism? Yes, majority of your marking correct answer. Mayank, NEET PG, Gauri, Mrunal, Pranati Gupta, NEET PG, Ashish Saini, Satyani Pal, Trilok Chand Sangam. Yes, fine tremors are seen in patients who are having hyperthyroidism, especially the Graves' disease. These fine tremors are seen in fingers and tongue. Here, the patient is having classical signs and symptoms of hypothyroidism. So, what is the correct answer? A. One question for you people. The patient of hypothyroidism is having bradycardia or tachycardia? Obviously, bradycardia. Another question. The patients of hypothyroidism are having hypotension or hypertension? I am waiting for your reply. Patients of hypothyroidism are having hypotension or hypertension? I am waiting for your reply. Shreya Patel, yes. Very good. Swati, very good Swati. Okay, majority of your marking hypotension. See, this is the catch. You have seen some of obese ladies who are having thyroid disorder. They are coming to medicine OPD and they are taking antihypertensive. You have to remember that patients of hypothyroidism are having diastolic hypertension. You have to remember this important point. Patients of hypothyroidism are having diastolic hypertension. There is bradycardia, but there is diastolic hypertension. Clear? So Mayank Prajapati, you are correct. So correct answer is here A, hypothyroidism. Okay. Next question. You tell me what is the correct answer for next question. It's an easy question. I'm waiting for your reply. A 75 years old North Indian woman presented to OPD with complaints of fever since 1 month, generalized weakness, anterior neck swelling since 4 years. Since 4 years she is having swelling, but fever is there since 1 month. Swelling was rapidly progressing since past 3-4 months. There was pain over the swelling, hoarseness of voice. Means there is midline swelling, there is pain, there is hoarseness of voice. Can you tell me what's the cause of hoarseness of voice in this thyroid swelling? Patient further reported history of weight loss and decreased appetite. So there is anorexia and weight loss. Anorexia and weight loss, but no dysphagia, dyspnea or any cancer in the family. So this patient is actually having malignancy. First clue, 75 years old. The first clue, which thyroid malignancy is seen in 70 to 80 years of age? Which thyroid malignancy is having pain over the swelling? Which thyroid malignancy is having involvement of recurrent laryngeal nerve leading to hoarseness of voice? Yes? Very good. Sangam, Harjap, Gauri, Suri, Rumana Ali, Mayank Prajapati, Shreya Kumari, Sam Preeti, Swati, Bhunesh. All of you are marking correct answer. All of you are marking correct answer. What? It is anaplastic. So let me tell you, you can easily crack the question related to thyroid malignancy on the basis of age. See, papillary carcinoma thyroid, it is seen in which particular age group? 25 to 40 years. 25 to 40 years. Follicular and medullary, this is seen in 5th to 6th decade. Average age is 60 years, 50 to 60. Anaplastic, it is seen in 7th to 8th decade. 70 to 80 years, there is another malignancy which is seen in 7th to 8th decade in males, CA prostate. Carcinoma prostate, it is seen in 70 to 80 years of age. 7th to 8th decade, CA prostate. Clear? So in this case, what is the correct answer? Most of you mark the correct answer, and that is option number D. Let me tell you, some of the students, whenever we are talking to the students, they have some kind of fear of lengthy questions. You should not have any kind of fear of lengthy questions. Why? Because if the question is big, it means there are lots of informations given in the question. You can pick even 3-4 informations. On the basis of that, you can mark the correct answer. So don't have any kind of fear of image-based questions, lengthy questions. Let me tell you, the chances of marking a question correctly, it's directly proportional to length of the question. So don't have any kind of fear of image-based questions, lengthy questions. What is the advantage of image-based question? That there is additional information provided in the form of images. Sometimes just by looking at the image, you can mark the correct answer. Clear? So don't worry, definitely you are going to do good. You are going to do good in the coming exam. Keep studying. See this question. Question pattern is similar, but only options are different. See, 45 years old male presented to cardiology OPD with left-sided chest pain. He was having left-sided chest pain. ECG, 2D echo, it was normal. On further questioning, patient told about dysphagia. So there is chest pain and the patient is having dysphagia. Patient is having chest pain and dysphagia. Patient is having dysphagia. Here you can see the barium swallow image. What kind of appearance is this? Barium swallow image. What kind of appearance is this? Yes, in barium swallow image you can see there is corkscrew. Corkscrew appearance. This is also known as rosary bead appearance, also known as pseudo-diverticular appearance. Means the diagnosis is diffuse esophageal spasm. Now comes the question, which of the following is responsible for this condition? It's a tricky question. Let me see who marked the correct answer here. Out of option A, B, C, D, E, let me see who marked the correct answer here. Yes, nobody till Prashant Verma, the first person. Prashant Verma is the first person to mark the correct answer. Very good, Prashant. Very good. Kalpana also. Kalpana, Prashant and Kalpana. Sayantani, Pal, Ashish Saini. Yes, see, there are three types of esophageal contraction. One is primary contraction. What is primary contraction? Whenever you eat something and then you swallow, this primary contraction starts from cricopharynx and it goes till GE junction. Okay, it is initiated by swallowing. It is peristaltic contraction. Second, secondary contraction. In the esophagus somewhere, the food stuff is stuck. So it is going to cause irritation or distension. So what happens? Locally, there is peristaltic contraction. It is caused by irritation or distension. Sometimes there is non-peristaltic spasmodic contraction, and that is known as tertiary contraction. Tertiary contraction, it is non-peristaltic spasmodic contraction, and this spasmodic contraction is responsible for diffuse esophageal spasm. So correct answer is C. Correct answer is C. Okay, Dr. Ravi also marked the correct answer. Dr. Ashish Saini, he also marked the correct answer. Clear? So it is C. The question which is frequently asked in exams, it's this kind of appearance. This radiological image is given. So what is this appearance? Corkscrew appearance, rosary bead appearance, also known as pseudo-diverticular appearance. This is also known as pseudo-diverticula. This is known as pseudo-diverticular appearance. Okay, this is diffuse esophageal spasm. This question is being asked continuously in exams from the last 4 years. In AIMS, in INICT, NEET PG, FMG, in all exams this question is being asked. I am sure it will be asked in NEET PG also. What? Foreign body, ingestion, coin. Where is the coin? Where is the coin? Yes, everybody. Reformer, Debopam, Milan, Dr. Dreamer, NEET PG, Elsa, Swati, Shefali, Milan, Mahendra, Samir, Rumana Ali, Vinod Raj, Milan, NEET PG. Everybody is marking the correct answer. That is what? Esophagus. It is very easy to mark the correct answer on the basis of symptoms. Simple question. If a child is going to swallow the coin is in the esophagus, child might be having difficulty in swallowing. That is dysphagia. When coin enters in the trachea, child will be having dyspnea. So you see the question. 5 years old child brought to the emergency by mother with difficulty in swallowing for past 5 hours. He was noted to play unsupervised. X-ray was taken. Identify the location. So patient was having difficulty in swallowing. Most probably it's in esophagus. And here, if you see this image, X-ray image, on PA view, what we can find? Flat surface of coin. And on lateral view, what we can see? Edge of coin. And you can see clearly in front of this coin, this kind of shadow, and this is tracheal shadow. It means the coin is in the esophagus. How to identify where is the coin? If you go for the PA view and if you can see the edge of coin on PA view, edge of coin, on lateral view the flat surface, it is in trachea. On PA view you can see the flat surface and on lateral view you can see the edge, it is in esophagus. In trachea the patients are having dyspnea, esophagus patients are having dysphagia. Dysphagia. Okay, how to remove the coin? Basically, it is done by ENT people. They perform the bronchoscopy and after performing bronchoscopy, they remove the coin. Okay. What happens if the coin is in esophagus? Remember, if coin crosses cricopharynx, we leave it. Why? Because usually it's excreted. What's the anatomy? You know that the narrowest point of GIT, it's a cricopharynx. Diameter is 1.5 centimeter. Any foreign body which crosses cricopharynx can be observed except if it's a sharp foreign body like blade, like nail, or if it's a button battery, the button batteries which are used in the wristwatches. Clear? Because these are having hydroxide, lithium hydroxide, sodium hydroxide, potassium hydroxide. And you know, alkalis are more dangerous than acid because alkali causes liquefactive necrosis. Clear? So here, what is the correct answer? The correct answer is A. Correct answer is A. Yes, we have to remove the magnets also, Dr. Dreamer. This question, tell me what is the correct answer. In a child during elective surgery, this abnormality was detected incidentally. Which of the following statement is incorrect? All of you can see what is the diagnosis here. All of you can see here what is the diagnosis. Obviously, it's Meckel's diverticulum. Now you tell me what is the answer. Debopam, Simran, Dr. Rao, Shreya Patel, Bhuvanesh, Gauri, Trilok Chand, Reformer, Sam Preeti, Anubha Singh, Dushyant, Elsa, Dr. Dreamer, Kalpana, Mahendra, Healthy, MedTalk, Sharmila, Arun, Mrunal Gunjal, Harshita, Limo, Gauri, Vinod Raj, Bhuvanesh. Everybody is marking correctly. This is the Meckel's diverticulum. You know, this is the true diverticulum. It contains mucosa plus submucosa plus muscularis propria. And you know, there is presence of ectopic mucosa. What is the most common ectopic mucosa? It's the gastric mucosa, followed by pancreatic mucosa, followed by colonic mucosa. GPC, how to remember? Mnemonic is GPC. Gastric, pancreatic, colonic. Since there is gastric mucosa, it bleeds. Why? Because it is going to cause ulcer. That's why the most common presentation, it is bleeding. And how you can detect it? How you can easily detect the presence of ectopic gastric mucosa? With the help of technetium pertechnetate scan. So first option is correct. Contains mucosa, submucosa, muscularis propria. Diagnosed by technetium pertechnetate scan. Bleeding, most common presentation. Most common ectopic mucosa, it's not pancreatic, it is gastric. So what is the correct answer? The correct answer is option number B. Option number B, Dushyant Gadekar, correct. You are correct. Option number B, this question was asked in INICT. Most common is gastric, followed by pancreatic, followed by colonic. Now read this question. I am waiting for your reply. All of you, everybody. A middle-aged man complains of upper abdominal pain and vomiting after heavy meal. There is tenderness in upper abdomen, tenderness, chest x-ray, widening of mediastinum along with pneumomediastinum. Pneumo means presence of air in the mediastinum. Vomiting, there is pain, there is pneumomediastinum, air in mediastinal space. What is the diagnosis? Everybody, yes, Rumana Ali, Bhunesh, Sharmila, Dreamer, Shefali, Praniti, Gupta, Sam, Preeti, Trilok, Chand, Sangam, Shefali, Suresh, Simran, Ashish, Saini, Swati, Anubha Singh, Mrunal, Gunjal, Need PG, everybody is marking correct answer. All of you, you know that this is a case of spontaneous esophageal perforation. Why? Because after heavy meal, patient vomited. What is the problem? Whenever patient is going to vomit, generally what happens? Abdominal pressure is going to increase. It pushes the stomach. So what happens? LES is going to open, glottis is going to open, and then content is coming out. Whenever there is incoordination and the glottis is not going to open, there is very high pressure in the esophagus. And esophagus is going to perforate along the weakest part of esophagus. Where? It is going to perforate in the left posterolateral direction. And you tell me it is characterized by plain, it is characterized by a triad. What are the components of triad? There is thoracic pain. I am asking the name. Tell me guys, what's the name? Thoracic pain. There is vomiting. And there is cervical subcutaneous emphysema. Tell me guys, what's the name of this triad? Limo. First person to reply, Limo. Very good, Limo. Ashish Saini, Sayantan Basu, Basit Alstaf Shah, yes, Dark Knight, Bhunesh Mayank Prajapati, yes, all of you, cervical subcutaneous emphysema, all of you are marking the correct answer. This is Mackler's triad. So this is spontaneous esophageal perforation, also known as Boerhaave syndrome. It is characterized by Mackler's triad. Okay, why not rupture of emphysematous bulla? In rupture of emphysematous bulla, it is not related to vomiting, not related to abdominal pain. Foreign body in esophagus, it doesn't lead to what? Pneumomediastinum, peptic ulcer perforation, there is no pneumomediastinum. So correct answer is D. This question is asked every year in each and every paper, and we are expecting this image based question again in NEET PG. A 60 years old male, known case of coronary artery disease, taking NSAIDs, was brought to the emergency with pain abdomen. On examination, tenderness was present all over abdomen with BP of 90/60. Chest X-ray is given below. What you can see in the chest X-ray? There is free gas under right dome of diaphragm. Free gas under right dome of diaphragm. Yes, Lovely, Goldie, Shiana, Setia, Sangam, Paneer Selvam, Mahendra, Sameer, Shreya Patel, Healthy Medtalk, Miracle Begins, Shruti Srivastav, everybody, Vinod Raj, Gauri, Mrunal Gunjal, Shruti Srivastav, everybody is marking correct answer. It's a case of perforation peritonitis because there is pneumoperitoneum. In patients of perforation peritonitis, since they are usually in the state of shock, you resuscitate the patient with IV fluids and then take the patient and perform laparotomy. So what is the correct answer here? IV fluids and laparotomy. Conservative management is not done. Ultrasound not required because there is free gas under right dome of diaphragm. Emergency laparotomy is done, but after resuscitation. So correct answer is here A. This question is very, very important. It's an integrated question of surgery, pathology and radiology. I'm waiting that who is going to mark the correct answer. Yes, a 60 years old female, see the age, 60 years old female, presented with dull aching pain in central abdomen. On evaluation, amylase and CEA was normal. Amylase and CEA, these are normal. CT abdomen and tumor cut section after surgery is given below. First, the question is, you guys tell me what is the name of this appearance on CT. On CT, very good, Sayantan Basu, Ashish Saini, very good. It is a central stellate scar. Which kind of calcification is seen here? Tell me. I'm waiting for your reply. Central stellate scar. What is the name of this calcification? I'm waiting for your reply. Let me see who is going to answer this question first. Calcification, 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 not the scar. Central what? Central which calcification? I'm waiting somebody. Yes. Not dystrophic. It is central sunburst calcification. It's a potential question of radiology. What's the name? This is central sunburst calcification. This is central sunburst calcification. Sunburst calcification. See, dystrophic and metastatic calcification, these are pathological findings. It's not radiological finding. So this is central sunburst calcification. And if you see the tumor grossly, there are microcyst. So this is microcystic. Now I'm waiting for the reply. What is the correct answer, guys? Tell me the correct answer. Christina Maria Paul. Christina Maria Paul. You are correct. Absolutely correct. Miracle Begins, Sangam, Swati, Shefali, Anubha Singh, Dr. Rao, Radha Shri. No, Radha Shri, it's not mucinous cystadenoma. It is not mucinous, it is serous cystadenoma. It is typically microcystic. Amylase and CEA is normal. So this is serous cystadenoma. Let me tell you, this cystic neoplasm is very important. So what happens? How to differentiate? In serous cystadenoma, what? amylase and CEA. This is normal or this is decreased. But in mucinous cystadenoma, only CEA is increased. Raised CEA in IPMN both amylase, as well as CEA, both of these are raised. Term is self-explanatory. Serous cystadenoma, so content is serous. Mucinous cystadenoma, content is mucinous. IPMN, intraductal papillary mucinous neoplasms, here also content is mucinous. Yes, so everybody, yes, everybody is almost correct. Correct answer is serous cystadenoma. It's a potential question. Again, a potential question, and this is a repeat question. Tell me the correct answer, guys. I'm waiting for your reply. A 60 years old diabetic male patient presented to OPD. Diabetic male patient presented to OPD with dysphagia, halitosis, regurgitation. Barium swallow is given. You can easily mark the correct answer. This is Zenker's diverticulum. Now, what's the correct answer, guys? Tell me. Mrunal, Shashank, NEET PG, Mayank Prajapati, Dushyant, Shefali Datta, Lovely, Goldie, Trilokchand, Abhijit, Reformer. Majority of you are marking the correct answer. It's elderly diabetic male. In such patients, the treatment of choice is cricopharyngeal myotomy. What's that? We are going to fix the diverticulum to the prevertebral fascia. So this is diverticulopexy. Now nothing will collect in the diverticulum, and if nothing will collect, what? The patient will not be having any complications. Why I am not going for diverticulectomy in diabetic patient? Because if you go for diverticulectomy, there is a suture line. Diabetic patients are having macroangiopathy, microangiopathy, which is going to increase the risk of leak. That's why diverticulopexy is a safer option. That is the treatment of choice. So it is cricopharyngeal myotomy plus diverticulopexy. B. In which case diverticulectomy whenever the size is more than 4 centimeter. POEM. POEM is done for achalasia cardia. What is the full form of POEM? It is per oral endoscopic myotomy. POEM is per oral endoscopic myotomy. It is for achalasia cardia. And what is Dohel-Mann procedure? This is diverticuloesophagostomy. Diverticuloesophagostomy. So what we do here, we put one limb of stapler in the diverticulum, one in the esophagus, and we perform the stapling. Clear? So Rameshwar Nayak, you are correct. Correct. Rajesh, you are correct, using stapler. So correct answer is B. So here you can see this is Zenker's diverticulum between oblique fibers of thyropharyngeus and transverse fibers of cricopharyngeus. This is Killian's dehiscence. There is herniation of only mucosa plus submucosa. So it's a false diverticulum. Most common esophageal diverticulum, that is Zenker's. Again, it's a potential question because this question was asked in INICT, NEET PG, FMG many times. Just by looking at the image, you can answer. Just by looking at the image, you can answer. Tell me what's the correct answer. First person to reply, Ashish Saini, Rajesh, Swati, Limo, Shefali, Sangam, Vijay, Dr. Rao, Samir Sarote, Ritika Singh, Dr. Reformer, Elsa, Miracle Begins, Anubha Singh, Bushra. You people are so fast that I'm not able to read all the names. I'm really sorry. Tariq, Sampat, Josephine. All of you are marking correct answer. You know what's the name of this appearance? This is claw sign. And in which case this claw sign is seen? You can see here that one loop of bowel enters into another. This is intussusception. So read the question. Child was brought to the emergency with abdominal pain, multiple episodes of bilious vomiting, diagnosis based on the given image of barium enema. It is claw sign seen in intussusception. These are the signs which are seen. This is claw sign, and you can see another sign which is seen in intussusception, coiled spring sign. Why there is coiled spring sign? You can see one bowel loop enters into another. So what happens? You can visualize the internal lining. So this is intussusception, in which there is coiled spring sign. Shahrukh Ahmed wants to ask that what is the cause of intussusception? See, in majority of cases, the age is 4 to 10 months. 4 to 10 months, and in majority of cases it's idiopathic. It is considered that there is Pierce patches hypertrophy because of infections like rotavirus diarrhea. So rotavirus diarrhea as well as rotavirus vaccine, both of these are going to cause intussusception. Majority of cases idiopathic. Sometimes there is a lead point like Meckel's diverticulum, like polyp, which can initiate the intussusception. Next question, very easy question. It's a repeat question. It's a repeat question. On the basis of image itself, you can mark the correct answer. 40 years old female. History of progressive dysphagia for both solids and liquids. Dysphagia is there for both solids and liquids for last 8 months. BMI only 18.5 means she is having weight loss. Without any systemic illness. Barium swallow showing rat tail, showing bird beak appearance. What other investigation should be done in the patient? Tell me guys, what is the correct answer? It's a tricky question. I'm waiting for your reply. Let me see who is going to mark the correct answer for the first time. First, yes, majority of you, Suresh, Tariq, Mehndi, Ashish, majority of you, Manius, Rabani, Miracle, Sampath, Dark Knight, Gauri, Shahrukh, Adnan, Bijapur, Vijay, Meena, Swati, Radha Shri, Cheru, Kutotha, Rumana Ali, majority of you are marking the correct answer. This is a case of achalasia cardia, and how you confirm the diagnosis of achalasia cardia by manometry. In motility disorders of esophagus, investigation of choice for diagnosis, manometry. You know that long duration achalasia, it's a risk factor for squamous cell carcinoma. So you can rule out malignancy by endoscopy. So what? We perform upper GI endoscopy and high resolution manometry. Investigation of choice for diagnosis. Investigation of choice for diagnosis is manometry. So here also pencil tip, yes guys, majority of you mark the correct answer. We are not going for 24 hours pH monitoring. You know that 24 hours pH monitoring is done in which case? GERD. It is done in GERD. So these are frequently asked image based question. You can see bird beak sign, rat tail sign, also known as pencil tip appearance. In certain books it is written that rat tail appearance it is seen in carcinoma esophagus. That is actually rat tail filling defects. In carcinoma esophagus, actually speaking, there is rat tail filling defects. So it's the rat tail filling defects which is seen in carcinoma esophagus. This question, easy question. Tell me what is the correct answer. I'm waiting for your reply. Waiting for your reply, guys. Old man presenting to emergency following a bout of prolonged vomiting with excessive hematemesis following alcohol ingestion is likely to suffer from. He took alcohol. After that, he was having vomiting and then excessive hematemesis. Nothing else is available in the history. Tell me, what's the problem? Bleeding disorder, it's not related to stomach. In carcinoma stomach, it's not related to alcohol. Alcohol is not a risk factor. Second, there is no hematemesis usually in carcinoma stomach. Esophageal varices, yes, there is hematemesis, but only single episode of alcohol is not sufficient. Patient should be having history of chronic liver disease. Tell me guys, yes, everybody, Shefali, Gauri, Tariq, Suresh, Miracle Begins, Sangam, Tariq, yes, Tariq, Gauri, Yadav Sanjay, Rameshwar Nayak, Ashish Saini, majority of your marking correct answer. Why it's not esophageal varices we discussed? It is not Boerhaave syndrome. In Boerhaave syndrome, hematemesis is not there. What happens? There is thoracic pain, vomiting, cervical subcutaneous emphysema. For hematemesis, there must be some bleeding source. And here is the left gastric artery which is the source of bleeding. So see here, This is the tear. It's the partial tear involving only mucosa and submucosa. What kind of tear? Partial tear, and it's a longitudinal tear. Because of this, there is bleeding. So this is Mallory-Weiss tear. In Boerhaave syndrome, there is full thickness perforation in esophagus. Mallory-Weiss syndrome, it's the partial tear in stomach. And what is the most common site? It's cardia. It's the stomach. Most common site is cardia. Okay. Next question. Again, it's a tricky question. I'm waiting for your reply. Let me see who is going to mark this question correctly. A 40-year-old male presented to emergency with abdominal pain and one episode of hematemesis. One episode. On CT, tumor was arising from stomach. This is the stomach. Tumor is arising from stomach with extraluminal growth. The tumor is growing outside, not in the lumen. It was localized. Tumor is CD117 positive. The biggest clue for this tumor, it is CD117 positive. What is the name of tumor? Rajesh, very good. GIST. Rajesh, you are correct. Absolutely correct. Shrutri Srivastav, very good. It is GIST. Dr. Dark Knight, GIST. Yes, majority of your marking correctly, it is GIST. Since it's a localized GIST, for localized GIST, what is the correct answer? How you resect it? See, this kind of resection. For localized GIST, we go for segmental resection or wedge-shaped excision. If it is unresectable GIST, in that case, imatinib. Imatinib is given in unresectable GIST. Unresectable GIST, imatinib. And if it is resectable, yes, if it's resectable, we go for segmental resection. So correct answer is A. Correct answer is A. Miracle Begins, wedge-shaped resection. Okay. Okay, somebody wants that highlighter should be used. Okay, I'm using highlighter. So what is the important point? Abdominal pain, one episode of hematemesis arising from stomach, extraluminal growth, CD117 positive. Clear? So these are the important points. Correct answer is what? Just thank you for suggestion. Thank you, Mota Bhai. Thank you very much. Rajesh wants to tell that biopsy is contraindicated. Yes. Why? Because if you try to do the biopsy, what will happen? If you try to do the biopsy, the tumor might rupture. The tumor might rupture if you try to do the biopsy. Okay. Next question. An infant after 4 weeks of birth. Clues are infant, 4 weeks of birth, was brought with history of multiple episodes of non-bilious vomiting. Multiple episodes of non-bilious projectile vomiting. X-ray is given below. What is the diagnosis? Tell me. Tell me guys, what's the diagnosis here? I'm waiting for your reply. NEET PG wants to say, somebody wants to say that it's double bubble. Miracle Mornings, hypertrophic pyloric stenosis. Yes, somebody, duodenal atresia. Yes, but majority of you are marking what? Hypertrophic pyloric stenosis. Imagine, even if this X-ray is not given. Infant, only 4 weeks of birth, multiple episodes of non-bilious vomiting, in ileal atresia, in jejunal atresia, even in duodenal atresia. In all these three, there is bilious vomiting. On the basis of question itself, you can mark the correct answer. And what is the typical appearance here? You can see this is the stomach. This is the stomach. Here, the whole stomach is distended. The stomach is distended with what? Whole stomach is distended with gas. So this is single bubble. In which case you can see double bubble. You can easily see here. This is single bubble. Double bubble, you can see the fundus and first part of duodenum. And triple bubble, here you can see stomach, duodenum, and this is DJ, duodeno-jejunal junction. So this triple bubble, it is seen in jejunal atresia. Double bubble, it is seen in duodenal atresia, and annular pancreas. It is seen in annular pancreas. Clear? And all of you know that single bubble, it is seen in hypertrophic pyloric stenosis. Single bubble, it is seen in hypertrophic pyloric stenosis. Clear, guys? So this is correct answer. Correct answer is hypertrophic pyloric stenosis. Okay, somebody wants to ask that, sir, please share PDF. Definitely we'll share the PDF here in the chat box itself. Don't worry. After some time in this video link, in the video message only, we are going to share it. Now this question. Image showing rectal prolapse in 45 years old female. What is the perineal approach for rectal prolapse? Which of the following is not the perineal approach? Okay. So, first, what are the abdominal approaches? How to remember? Mnemonic is VAR. A means abdominal, W means Wells and Ripstein. And what is perineal approach? How to remember? Perineal approach, mnemonic is PAD. For perineal, it is PAD. P means perineal, A means Altmier's, D means Delorme. Altmier's, D means Delorme. You know that Thiersch is also perineal approach. Clear? So what is the correct answer? Let's see how many of you mark the correct answer. Yes, Miracle Begins, Maniyush Rabbani, Dr. Pranati Gupta, Dr. Sangam, Dr. Bushra Bano. Miracle Begins, Oikawa, Tariq Mehdi, Prashant Verma, Adnan, Ashish Saini, Samir Sarote, Shefali Satankar, Sai Oikawa, Radha Shri Cherku Hota. Lovely Goldie, all of you marking correct answer here. Ripstein. Ripstein is abdominal approach. This is abdominal approach, it's not the perineal approach. So correct answer for this question is option number A. Option number A. Again, it's a repeat question. Tell me what is the diagnosis just on the basis of image itself. Just on the basis of image itself, tell me guys what's the diagnosis. 30 years old male with recurrent painful perineal nodules on buttock. Recurrent painful perineal nodules on buttock with serous discharge. Image is given below. What's the diagnosis? Tell me. Everybody is marking C. Elsa, Harshita, Meghna, Gauri, Mitali Gupta, Harshit Kumar, Mayank Prajapati, Shruti Srivastav, Atul Thakur, Sangam, Anubha, Shreya Patel, Prashant Verma, Mulla Aishul, Vinod Raj, Yadav, Healthy Med Talk, Harshit Kumar. All of you are marking correct answer. Very good, Shreya, Tariq Mehdi. It is fistula in ano. This is fistula in ano. Clear? And for fistula in ano, there is a classification known as Parkes classification. And what is the most common type of fistula? It is intersphincteric. The most common type is intersphincteric. Majority of you are correct. Bibek Yadav, Adnan, Bijapur, all of you are correct. Radhashri, you are also correct. Fistula in ano. Very good. So this is fistula in ano. Another question is a tricky question. Let me see who is going to answer this question. Yes, fastest person to reply. Let me see who is going to mark the correct answer here for this question. Appendectomy was performed in a patient with appendicitis. First, surgeon performed gridiron incision, later converted to Rutherford Morrison incision. Which of the following does surgeon needs to cut further? Which muscle is further cut? Yes, Miracle Mornings want to say that, sir, this time there was a question related to fistula in ano, investigation of choice, and you know investigation of choice is MRI. Yes, tell me. First person to reply, let me see, Prashant Verma, Academy, NEET PG, Ritika Singh, Sanjay Yadav, Elsa, Healthy Talk, Pranati Gupta, yes, Avinash. I'm just taking the names of people who marked the correct answer. Ashish Saini, Miracle, Mrunal Gunjal. See, it's very easy question. Have a look. This is the abdomen, okay? This is the umbilicus. This is anterior superior iliac spine. This is the line, spino-umbilical line. You know, on spino-umbilical line at the junction of medial 2/3, lateral 1/3, there is a point that is known as McBurney's point. We give incision perpendicular to this point, perpendicular to line joining, centered at this point. This is gridiron. If you are not able to visualize appendix, see, incision is extended upwards and laterally. So you have to extend the incision upward and laterally, and we are going to cut the conjoint tendon. So which muscles are divided? Conjoint tendon means internal oblique and transverse abdominis. 2 and 3 are further divided. So what is the correct answer here? C. C. Clear? So correct answer is C. Now next question. A 50 years old male presented to the hospital with colicky abdominal pain, bilious vomiting. If there is colicky pain and bilious vomiting, it means patient is having small bowel obstruction. On evaluation, air was present in CBD. If air is there in the CBD, it means there is pneumobilia. Pneumobilia, what is the diagnosis? Yes guys, let me see who marked. Vinod Raj, Shiv Kumar, Sangam, NEET PG, Prashant Verma, everybody, Dr. Dreamer, Bushra Banu, Harshit, all of you are marking what? Gallstone ileus. Yes, it's gallstone ileus. You know that gallstone ileus is characterized by plain X-ray triad known as Rigler's triad. This is Rigler's triad, guys. Plain X-ray triad, there is small bowel obstruction, pneumobilia. There is pneumobilia, and these patients have ectopic gallstones. These patients have ectopic gallstones. Clear? So, gallstone ileus is the correct answer. It's D. What happens? You tell me. In gallstone ileus, there is a fistula. Here you can see the stone. Stone is going into duodenum. So, what is the most common fistula in gallstone ileus? I am waiting for your reply. Most common fistula. I am waiting for your reply. Between gallbladder and duodenum? Yes. Waiting for your reply. Radhashri, Mayank, Shiva Kumari, Tariq Mehndi, Bushra Banu, Swaminathan, Ashish. Yes. No, it's not terminal ileum. NEET PG, coli. What coli? Coli? Cholecystoduodenal, first person Sayantan Basu, after that Dr. Dreamer. It is cholecystoduodenal fistula, and because of this the stone comes in duodenum. It is going to obstruct which part of bowel? Terminal ileum. So here there is ectopic gallstone. Because of this fistula there is air in biliary tree and there is obstruction. This is Rigler's triad. Now see guys, last question. Let me see who is going to mark it correctly. 55 years old patient underwent hysterectomy 2 years back. Now presented with colicky pain and bilious vomiting. Abdomen was tender, exaggerated bowel sounds, multiple air fluid levels on abdomen. Most probable diagnosis. I am waiting for your reply. Most probable diagnosis. All of you are marking Devpam, Sayantan, Vinaraj, Shiv Kumar, Sashank, Dreamer, Sangam, Ashish, Sani, NEET PG. Everybody is marking correctly what? Small bowel obstruction. This patient is having history of hysterectomy. It means because of previous pelvic surgery, there is adhesions. So this is adhesive small bowel obstruction. This is adhesive small bowel obstruction. So correct answer is A. In gastroenteritis, bilious vomiting is not there. In ischemic enterocolitis, what happens? In ischemic enterocolitis, there is fever sometimes. The pain is very severe pain because of ischemia. In gallstone ileus also vomiting is not there. Clear? So correct answer is what? Adhesive small bowel obstruction. So these were the questions. Guys, you are really highly interactive and I think your preparation is going on with a full-fledged speed. Keep preparing like this only, and tomorrow we will be discussing, or we will be coming live again at 6 p.m. and tomorrow we will be having the discussion of general surgery question, in which I will include urology, burn plastic, arteriovenous disorders, neurosurgery, head and neck, oral cavity and trauma, sutures, infections. These questions will be included. So thank you very much guys, really interactive and lovely crowd. Wish you all the best. I'm waiting eagerly for all of you for tomorrow. Till that, good luck. Love you all.